Okay, we are back. Dr. John Shu. John, are you ready?
I am.
Okay. Your time starts now. Your 10 minutes.
Okay, great. Thank you. I'm John Sue. I'm CEO and co-founder of the IPIL. I practice anesthesia and chronic pain management for 28 years. One day I was called to the ER. One of my young patients was in the ER with an opioid overdose. He was immediately treated with Narcan and had a short hospital stay and then was released. Everything sounds good at that point. About less than a week later, he returned. Same thing, opioid overdose, treated Narcan, stayed in the hospital, but then was released. And then I didn't see him ever again. There must be a better way to treat these patients. Let me ask the audience a question. Have you locked up your opioids today? This is important because 128 people, it's actually a little bit more than that now, die from the opioid overdoses every day. 1 in 4 opioid overdoses now involves children and teens. The problem starts at home. Opioids are triple locked in safes in hospitals and pharmacies. These same opioids are sent home with patients and are often left on the kitchen table or in a medicine cabinet, not very secure. The result, abuse, misuse, diversion, addiction, overdose. We've been hearing it over and over again in opioid litigation, in the media, everywhere. The solution is to secure opioids at home, just like it is in the hospital. We need to make sure only the person prescribed can access opioids at only the prescribed dose and time. How many of you have opioids sitting in your medicine cabinets right now? And we're all doctors. 73% of teens start abusing opioids obtained from their own homes. Our product is the IPIL platform, a tamper-resistant dispenser connected to a mobile app. The dispenser securely stores opioid pills. Any tampering leads to destruction of unused opioids in the dispenser. At the end of the prescription term, unused opioids are also automatically destroyed. The IPIL app on the patient's phone uses two-point authentication, so only the patient prescribed can access opioids at only the prescribed schedule, just like in the hospital. The IPIL is not just a medical device, it's a service. The IPIL app allows medication adherence monitoring and real-time monitoring of patient compliance. The clinician can see collected data in our portal to guide therapy. The IPIL dispenser securely stores opioids, destroys unused opioids with a DEA-approved solution to prevent accidental overdose of the patient and others who may get hold of the opioids, others being others in the household. Telling an OUD patient holding a bottle of pills not to take too many opioids is like having a wolf guard a chicken coop. Not very successful. That's why the opioid crisis is getting worse and worse. The IPIL product is an FDA Class 1 510(k) exempt device that can be sold today. Our future product is an IPIL Class 2 device. It consists of the IPIL Class 1 product plus a respiratory biosensor. The IPIL biosensor is to detect opioid-induced respiratory depression, terminating access to the opioids from the IPIL dispenser, and call 911 if opioid-induced respiratory depression is detected. The IPIL has 3 granted patents. The IPIL is a Class 1 registered product, 510(k) exempt. The IPIL Class 2 is a breakthrough device. It's on the FDA de novo approval pathway. Because a Class 2 is a breakthrough device, it will be the only dispenser covered by insurance. CMS said they, on January 12th of 2021, announced reimbursement coverage of FDA designated breakthrough products. The market for IPIL is expectedly large. We are focused on the opioid segment because of the opioid overdose rate, but It can be used for addictive drugs. The child-resistant cap that is used today, was developed in 1967 and made a federal mandate in 1970. No upgrades for 51 years. In the opioid crisis, it's 22 years. It's getting worse and worse. It switched from prescription opioids to illicit opioids. Illicit opioids cause 2/3 of opioid deaths, and prescription opioids only cause 1/3. Still important though. Restrictions on opioid access has pushed patients to illicit opioids as evidenced in the COVID-19 pandemic. The important connection between illicit and prescription opioids is that 86% of heroin and fentanyl addicts first report abusing prescription opioids as teens. It's a gateway. We must treat pain, but we must do it in a better way. The iPill is to be sold B2B. Our first target customer is OUD clinics, opioid use disorder clinics. There's 14,500 OUD clinics with a market cap of about $2 billion annually. We have traction with 2 OUD clinics. They came to us. We didn't market. We have not marketed yet. We have 2 purchase orders with a potential of $7.7 million annually in sales from just those 2 orders. They see iPill as a way to reduce relapse rates and reduce non-emergency medical transport costs. Relapse rate, 27% on the first day after discharge, 65% in 30 days, 90% in 1 year. Non-emergency medical transport costs per year per patient, $20,000 to $24,000. What OUD clinics can use us for is to increase value-based contracts at higher reimbursement rates. Business use cases. We're working with a digital health company that owns a pharmacy. They send 5,000 opioid prescriptions to patients, put patients' homes a month. Their pain point is they cannot monitor medication adherence and take on liability that they can't control. They fear being part of the opioid litigation that's sweeping the country. They see iPill as a tool to monitor medication adherence, improve care, and increase, again, their business, volume-based contracts. This is a $9 million revenue opportunity. We're also working with the manufacturers of of Omnicell and Pyxis, which are refrigerator-sized vaults that securely stores opioids and other addictive drugs in the hospital. They have a desire to sell the iPill under their logo to expand their market from the hospital and into patients' homes. What this means for iPill is that our cost of customer acquisition will be extremely minimized. Someone else is going to sell our device for us. The iPill offers more features at less cost than competitors. We offer biometric authentication for active control dispensing, destruction of pills. No one's doing that right now. With tampering and at prescription end, we can remotely destroy tablets at the end of 30 days. We can collect data to allow clinicians to monitor medication adherence to guide therapy. The senior management team has had multiple startups and exits. The full team has over 100 years of clinical, regulatory, logistics, and manufacturing experience. We are supported by advisors that include a former FDA director, Foxconn, the makers of the iPhone, and a logistics company that has a pharmacy and repackaging license in all 50 states. This is important because we can actually send our iPill to patients' homes so we can increase the safety of physicians who want to use the X waiver to give patients Suboxone. It's amazing. Suboxone has decreased overdose rates by 50%, but only 1/3 of OUD clinics use it. It's a gold standard. They fear liability. They fear patients overdosing or selling their Suboxone. Thank you very much. I'm open for questions.
Great. That was really interesting, John. I a couple of questions. So right now, who is paying for the pill? Like, is it something that you would prescribe it and the pharmacist would give it to the patient and it would go through their billing? As in the outpatient setting, who's paying for the pill pack?
Well, right now, the OUD clinics want to pay for it. We're charging them $50, and they're saying we pay more. You're only charging us $50. We're going to save money on the non-emergency transportation costs, and we're going to get more contracts. So the one OUD clinic, they actually went out to Optum and United Healthcare, and they got more value-based contracting because now they told them that we're using a secure device that we can get to your patients at their homes. So they got more contracting, value-based contracts right away.
So
they're actually paying us cash.
So, so the other question I had was that, you know, as a surgeon, we don't write prescriptions for opioids anymore because in Massachusetts, you have to log in and go through it, you know, so our prescription writing for opioids has dropped dramatically. But I wonder, with the movement toward outpatient surgery, like outpatient knee replacement and so forth, patients are going to need to go home on something. Also, inpatient units with patient-controlled analgesia. Is there any thought of using this as an inpatient tool for, you know, we give patients pumps with PCAs, but they could potentially have an oral dispenser that could give them access to their medication instead of waiting on a call button for a nurse to come and give it to them?
Like an onion, we need to peel layers at a time. The lowest hanging fruit is OUD clinics. They will pay us cash every single day. The next case is, who's going to pay for this? We need to get our class 2 device, which is a breakthrough device, which is going to be covered by CMS, Medicare, Medicaid. And so therefore, then we can get it into the hospitals, into everywhere, because it'll be paid for by insurance. If you don't cover something that Medicare covers, you will lose your Medicare contract. We need to get some industry traction. We need to get our human factor study trials done, which are going to be done in Q3. Once we get that done, we're selling our product. We've actually gone to major pharmacy chains like CVS, Aetna, and they said, we want to have industry traction before we put it in our 10,000 pharmacies. So you're right. That's a future event.
Right.
Also have a question, if I may.
Sure.
Thank you for your presentation. I'm thinking about social determinants of health and use of cell phone among the people who are dealing with opioid overdose. Do you have any data on how many of these people have cell phones? And regardless, are you just trying to target those who have cell phones, or are you thinking about some kind of verification for those who may not have smartphones?
3 things to tell you. Number one, 85% of the US population has cell phones, according to Pew Research. If you don't have a cell phone, what I can do at $30, I can arrange to get an IoT. I can arrange a smartphone for you through a company called Choice IoT. And number 3, if you don't have the money for that $30, I can, of course, arrange a Obama phone for you for free. So I don't want to say that a smartphone is going to limit your ability to get opioid treatment, because we need to treat these people. It costs us $696 billion a year in unemployment, homelessness, crime, medical expenses. And a $30 cell phone is going to prevent me from being able to address that? I don't think so. This has to happen.
So are you targeting for 100% of opioid prescriptions going through your device?
Right now, but as you can see, this is a cartridge. So the cartridge can actually hold 120 Percocets, and I can put it in the dispenser. So the reason for the cartridge, I can change it to 120 pills of Percocet or hydrocodone later. But I need to get the business off the ground. I need to get the industry to accept it so that it can move on. I'm not going to attack the whole industry as a whole because I'm going to fall flat on my face. I don't have enough money. I'm paying for this myself. I'm retired and I'm paying for this myself. I don't have enough money to do that right now.
And what's your margin just in terms of manufacturing it and selling it?
I'm doing the injection molding in Taiwan. That's where I'm building getting the injection molds. I'm building the devices with Foxconn at an ISO 13485 factory in Mexico. That means I avoid China, a 25% surcharge. I avoid shipping. My COGS right now, estimated less than 15. Margin, 70%.
Okay, judges,
Thank
it's
you.
time to make a decision. Thank you very much, John,